Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the multiple audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Masamichi Kurosaki. Professor Kurosaki is a professor in the Division of Neurosurgery at the Department of Brain and Neurosciences, Tottori University Faculty of Medicine, Japan. He has a vast experience in the management of skull-based tumors, especially treating the tumors of the pituitary gland endoscopically. He is a member of the Japanese Endocrine Society, Japan Society of Skull-Based Surgery, and Japan Society of Pituitary and Hypothalamic Tumors. He has published several articles in various peer-reviewed journals, and we are extremely honored to have him today with us as a speaker for our webinars. And today he will be talking about treatment strategy for hypothalamic and pituitary tumors based on imaging findings. The speaker for the second session of today is our very honorable guest from China, Professor Shai Rong. Professor Rong is a chief physician, professor, and doctor supervisor in the Department of Neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He also serves as the adjunct professor and doctoral supervisor in the Department of Neurosurgery at the first affiliated hospital of Fujian Medical University. His clinical expertise of interest is focused primarily on the clinical diagnosis and surgical treatment of craniovertebral junction, spinal cord, and neurospinal disorders, as well as research on key mechanisms underlying spinal cord function protection. He is a noted author who has published more than 30 papers in internationally reputed peer-reviewed journals, and is also involved in academics and has supervised more than 10 masters and doctoral students. We are extremely honored to have him today with us, and today he will be talking about cerebrospinal fluid decompression strategy for hair malformations. The chair for the first session of today is our honorable faculty from Mexico, Professor Juan Luis Gomez Amador. Prof. Amador is a professor of neurosurgery and director of skull-based and endo neurosurgery program and director of the Advanced Neurosurgical Training Center at the National Institute of Neurology and Neurosurgery in Mexico City, Mexico. He is the president of the Mexican Board of Neurological Surgery and president of the neuroendoscopy section of the Mexican Society of Neurological Surgery. He is a member of the Yasser Gil Microneurosurgical Academy and former president of the Academic Affairs of the Flank and former president of the Neurosurgical Academy Committee of the WFNS, former chairman of the Neurosurgical Division of National Institute of Neurology and Neurosurgery. His clinical interests are primarily focused on minimally invasive neuroendoscopic procedures. We are extremely grateful to him for accepting an invitation to chair the session of Professor Kurosaki. The chair for the second session of today is our honorable faculty from Italy, Professor Massimiliano Visocci. Professor Visocci is a professor of neurosurgery at the Catholic University of Rome, Italy, and visiting professor at the Shanghai University, China, the George University of London, UK, and the Mumbai University, India since 2012. He is the founder and chairman of the Research Center in Surgery for Craniovertebral Junction at the Catholic University of Rome, Italy. He also serves as a chairman of the operative unit of CVJ Surgery, ex-vice co-chairman, Neurorehabilitation and Reconstructive Committee of the WFNS, board member of the WFNS Trauma Committee and Educational Committee. He is the member of the VANS, and he is a member of 13 international and 9 national scientific societies, and he has been invited speaker for more than 350 international and national courses and congresses. He is a noted author for more than 400 papers and author of 6 monographic books and member of the continuing medical education of the Italian Health Ministry. We are extremely grateful to him for accepting our invitation to chair the session of Professor Shai Rong. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to welcome both speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting the webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Professor Amador.
It is a great honor to be here with you today. It is a great honor for me to present Professor Kurosaki. As you have heard before, he's a well-known expert in the field of skull-based surgery, and the topic he's going to address today is about how to combine these diagnostic studies in order to perform a precise and accurate surgical procedure. So with no more, we thank you, Professor Kurosaki. It's a great honor to meet you, and please go ahead.
Thank you for your kind introduction, Mr. Chairperson. It's my great honor and pleasure to be here today. My name is Kurosaki, and I'm a neurosurgeon from Tottori University, Japan. Today, I'd like to discuss the evolution of the WHO classification of pituitary tumors and its impact on clinical decision-making, particularly focusing on the role of imaging findings in treatment strategy. Let me first briefly review the historical evolution of the WHO classification. In the 2004 WHO classification, the concept of atypical adenomas introduced. Atypical adenoma was defined by three pathological characteristics. This is MIB1 proliferative index greater than 3%, excessive P53 immunoreactivity, and increased mitotic index. However, atypical adenomas were more likely to follow a clinical aggressive course with poor prognosis. I would like to present a rare case of an incidentally diagnosed atypical pituitary adenoma. MRI demonstrates a pituitary tumor with superior extension, and although the tumor slightly complex, the optic chiasm here, there was no obvious invasion into the cavernous sinus. An endoscopic endonasal transsphenoidal surgery was performed. Histologically, the tumor consists of chromophobic and weakly basophilic cells, marked cellular pleomorphism, and frequent mitotic figures are observed here. And these findings suggest a tumor with potentially aggressive characteristics. The MIB1 labeling index was approximately 20%. The tumor nuclei showed strong immunoreactivity for P53, and some tumor cells were positive for ACTH. Based on these findings, the final pathological diagnosis was here silent corticotroph atypical adenoma. Interestingly, despite these aggressive pathological findings, the clinical course was favorable. Radiological examination using CT, MRI, and PET of the whole body demonstrated neither cerebrospinal nor systemic metastasis. Follow-up MRI performed 13 years after surgery demonstrated no evidence of recurrence. Pathological features alone could not reliably predict clinical behavior. Therefore, the time atypical adenoma was no longer recommended in subsequent WHO classifications. And therefore, the term atypical adenoma is no longer. The experience emphasized the need for a more comprehensive approach to tumor classification. In the 2017 WHO classification, additional parameters with possible prognostic significance were incorporated. These included invasion patterns and proliferation markers, clinical characteristics, and radiological findings. The concept of pituitary tumor continued to evolve, leading to the publication of the fifth edition of the WHO classification in 2022. One of the most important changes was the transition from the traditional term pituitary adenoma to PITNET. The current classification is primarily based on the concept of tumor cell lineage. Transcription factors play a critical role in determining the differentiation pathway of pituitary cells. And among PITNETs, several subtypes are recognized as having a high risk of aggressive behavior. For example, sparsely granulated somatic tumor and corticotroph tumor, and so on. PITNETs are actually common reasons. Autopsy studies and imaging studies have suggested that pituitary tumors may exist in approximately 10% of the general population. However, the vast majority remain clinically silent throughout life. The real clinical challenge is identifying a small subset with aggressive biological potential. Let me now discuss how imaging findings can influence treatment strategies. First, I will focus on lactose PITNET prolactinoma. Dopamine agonists, particularly cabergoline, are widely accepted as the first-line treatment for lactose PITNET. Cabergoline has excellent efficacy in normalizing serum prolactin levels and reducing tumor volume, although significant shrinkage is frequently observed, complete disappearance of the tumor on MRI is relatively uncommon. Therefore, predicting treatment response is clinically important. This patient was a 37-year-old man who was referred to our hospital because of headache and visual disturbance. Because the serum prolactin level was markedly high, cabergoline therapy was initiated. This slide demonstrated the serial post-contrast T1 weighted images obtained using MRI. Before treatment, a large macro tumor with supracellular extension was observed. After 2 months of treatment, the tumor size had already decreased significantly. Further reduction was observed during follow-up. Interestingly, changes on T2 weighted MRI images provided additional information. Before treatment, the tumor showed relatively high signal intensity. During cabergoline therapy, a distinct low signal intensity area appeared within the tumor. At 4 months, this low signal intensity area extended throughout the tumor. Subsequently, marked tumor regression occurred. We investigated the relationship between MRI changes and tumor response. We found that the appearance of a distinct low signal intensity area during the early phase of cabergoline treatment was associated with pronounced tumor regression. Therefore, early MRI changes may serve as a predictive marker for treatment response. However, not all lactose PITNETs respond favorably. This tumor was discovered during evaluation for nasal bleeding. MRI revealed a large tumor extending from the cellar beyond the cellar taxa into the surrounding structures. Because the serum prolactin level was markedly elevated like this, cabergoline treatment was initiated. After starting cabergoline treatment, the prolactin level decreased rapidly. MRI demonstrated significant tumor shrinkage with 1 month. However, the patient subsequently developed cerebrospinal fluid rhinorrhea. Therefore, endoscopic transphrenoidal surgery was performed for tumor removal and reconstruction of the CSF leak. During surgery, diffuse intratumoral hemorrhage was observed. This finding was also confirmed histologically like this. The tumor consisted of atypical prolactin positive cells. The MIB1 labeling index was 6.5%. This case illustrates that some tumors may show aggressive behavior despite a good initial response to medical therapy. I'd now like to focus on somatotroph PITNETs. In acromegaly, preoperative prediction of tumor characteristics is particularly important because tumor biology strongly influences both surgical and medical outcomes. In somatotroph tumors, T2 weighted MRI signal intensity is closely associated with the granulation pattern like this. Densely granulated tumors generally show low signal intensity on T2 weighted images. In contrast, sparsely granulated tumors usually demonstrate high signal intensity. This difference reflects the ultrastructural characteristics of the tumor cells. The distinction between densely and sparsely granulated tumors has important clinical implication. Generally speaking, the sparsely granulated somatotrophic tumors are more aggressive. They tend to show large tumor size and higher invasiveness and reduced responsiveness to somatostatin receptor ligands. Therefore, identifying the granulation pattern before treatment can help determine the optimal therapeutic strategies. With the introduction of more stringent biochemical criteria 2010, the reported remission rate of acromegaly after surgery has decreased compared with previous reports. Recent studies have demonstrated that the most important factors associated with endocrinological remission extra-shoot capsular dissection and absence or presence of cavernous sinus invasion. The shoot capsule is composed of compressed normal pituitary tissue and fibrous tissue surrounding the tumor. In this article, the authors describe the surgical techniques that use the histological shoot capsule as a surgical capsule. This patient was admitted to our hospital with acromegaly. On post-contrast T1 weighted images, the tumor was clearly visible as a relatively less enhanced region surrounding the normal pituitary gland. On T2 weighted imaging, the tumor showed low signal intensity, suggesting suggesting a densely granulated somatotrophic tumor. The shoot capsule was clearly identified during surgery. Video shows that in this case, a so-called extra shoot capsule dissection was performed. After opening the dura, you can see the pituitary tumor. The tumor was separated from the normal pituitary gland, and here, this is the interface between the tumor and normal pituitary gland, and this section along to the medial wall of the cavernous sinus here. And after debarking of the tumor, you can see the here inner membrane of the cavernous sinus. The no definite invasion into the cavernous sinus was identified, and the complete tumor removal was accompanied. A small residual tumor was identified, and then subsequently removed. So endocrinological remission was achieved. Histopathological examination confirmed the densely granulated type. This case demonstrates the importance of integrating preoperative MRI findings, intraoperative anatomy, and pathological confirmation. A recent meta-analysis compared extra-shoot capsule and intra-shoot capsule resection. Extra-shoot capsule resection was associated with a higher rate of complete tumor removal and a higher rate of biochemical remission. Importantly, this approach did not increase post-operative complications. Therefore, extra-shoot capsular dissection represents effective and safe surgical strategies. Cavernous sinus invasion remains one of the greatest challenges in pituitary surgery. The medial wall of the cavernous sinus has become an important anatomical structure in modern pituitary surgery. This patient was also admitted with acromegaly. Contrast enhanced T1 weighted images show a relatively less enhanced area surrounding the normal pituitary gland. Video shows after opening the cell floor, you can see the cavernous sinus was visualized through the dura. The tumor is relatively firm, so using the shoot capsule dissection, the tumor was unblocked resection, and because invasion, cavernous sinus invasion could not be completely excluded, the medial wall of the cavernous sinus was removed. Here, this is the intra cavernous sinus using hemostatic. The patient had an uninventable post-operative course and achieved endocrinological remission. In this study, patients were classified into 3 groups according to the relationship between the tumor and the cavernous sinus. Group A, no clear invasion. Group B, possible invasion, and Group C, definite invasion. In Group B, the medial wall was removed and invasion could not be excluded. And histological examination confirmed the tumor invasion of the medial wall in 56% of evaluable cases. Importantly, almost all cases achieved endocrinological remission. These results suggest the selective medial wall resection may improve surgical outcomes in carefully selected patients. Finally, I would like to discuss sparsely granulated somatotrophic tumors. These tumors represent biologically more aggressive subtypes. Typically, sparsely granulated tumors show high signal intensity on T2-weighted images. However, when intra-tumoral hemorrhage is present, the lesion may appear hypointense. Therefore, interpretation of T2 signal intensity requires careful consideration of hemorrhage changes. So T2 star weighted imaging is useful for detecting the intratumoral hemorrhage. And histologically, the tumor demonstrated marked nuclear polymorphism, including multinucleated cells and abundant fibrous body cytokeratin positive. And electron microscopy revealed only a few secretory granules with prominent fibrous bodies. And these findings confirmed the sparsely granulated somatotrophic PITNET. Densely granulated tumors with low T2 signal intensity are generally more responsive to somatostatin receptor ligands. In contrast, the sparsely granulated tumors with high T2 signal intensity may require alternative treatment strategies. Thus, the imaging serves as a bridge between tumor biology and clinical management. I would now like to discuss silent corticotrophic tumor, SCT. Although these tumors do not cause clinical manifestations of Cushing's disease, they are derived from corticotrophic lineage and may show more aggressive behavior compared with other clinical non-functioning tumors. Therefore, identifying these tumors before surgery is important for appropriate treatment planning and follow-up. In the previous study, the diagnostic value of multiple microcysts is clinically non-functioning pituitary macrotumors were evaluated. The presence of multiple microcysts showed a sensitivity of 76% and specificity of 95% for predicting silent corticotrophic tumors. Therefore, this MRI finding may serve as a useful preoperative marker for identifying this aggressive subtype. This case demonstrated multiple microcysts like this within the tumor on preoperative MRI. Based on the characteristic imaging finding, a silent colorectal tumor was suspected before surgery. However, that tumor was negative for ACTH. Unfortunately, TPIT immunostaining was not available at our institution at that time, and further pathological confirmation could not be performed. Nevertheless, based on the characteristic MRI findings and clinical features, we speculated that this tumor represented TPIT positive silent colorectal tumor. ACTH negatively does not necessarily exclude colorectal lineage here. The current WHO classification emphasizes the importance of transcription factor expression, particularly TPIT, for determining colorectal differentiation. Interestingly, here you can see ACTH negative silent colorectal tumors appear to be more frequent associated with multiple microcysts. This suggests that the MRI may provide additional information regarding tumor lineage. Next, I would like to move on to craniopharyngioma. Craniopharyngiomas are currently divided into two major subtypes. The first is adamantinoma type, and the second is the papillary type. The tumor is driven by BRAF B600 mutation. This molecular distinction is clinically important because BRAF mutated papillary craniopharyngiomas may respond to target therapy using BRAF and MEK inhibitors. This slide summarizes the characteristic MRI findings of craniopharyngiomas. Calcification is commonly observed in adamantinomatous type. And another interesting finding is edema extending along the optic tract. Based on this finding, craniopharyngioma is suspected. However, the final diagnosis was radical cyst. This case also FLAIR indicated edema along the optic tract. Based on the finding, craniopharyngioma suspected. However, the final diagnosis was diffusion high, so radical cleft cyst associated with pituitary abscess. And this finding is important because squamous metaplasia in radical cleft cyst may mimic craniopharyngioma. Therefore, integration of imaging, clinical information, and pathological evaluation remains essential. Dr. Taguchi and his colleagues reported edema along the optic tract may predict the presence of BRAF B600 mutation in papillary craniopharyngioma. This represents another example of how imaging findings may provide information about molecular characteristics before surgery. The surgical management of craniopharyngioma has also undergone significant evolution. Historically, transcranial approach was the standard treatment. However, advances in endoscopic skull-based surgery have resulted in increasing use of extended endonasal approach. This case was treated approximately 20 years ago using a telional approach. After cutting the false hormone ligament, and the tumor's growth totally removed through the optic carotid recess. And after the removal of the tumor, you can see the superior hypophyseal arteries. Over the past decade, the conventional transfemoral surgery was evolved into extended endoscopic endonasal surgery. Among these approaches, the precellular transplant approach has become one of the most commonly used techniques for supracellular lesions. One of the most important anatomical considerations during craniopharyngioma surgery is preservation of the superior hypophyseal arteries. Preservation of these small but critical vessels is essential for maintaining visual and endocrine function. This video shows the cadaver dissection of precellular transplant approach. Now expose the optic canal at the right side and expose the cavernous sinus dura, and opening the wide sphenoidectomy is important. After cutting the dura of the tuberculum area, chiasm and pituitary stalk, and this is the SHA, superior hypophyseal artery, and optic oculomotor nerve, and PCS, mammillary bodies, the landmarks you can see. With the increasing complexity of skull-based surgery, surgical simulation has become increasingly important. Recently, patient-specific anatomical models can be created like this using 3D printing technology. These models are particularly used for surgical rehearsal, anatomical education, and training of young neurosurgeons. In our initial model, you can see the cranial nerves within the cavernous sinus were represented in less detail compared with actual anatomy. Then, however, this limitation has been improved in subsequent models. Using this model, the video shows the surgical approach like this, and opening the cell floor, you can see the normal pituitary gland, and this is artificial carotid and optic nerve. This is the model. And in this case, this patient presented with headache caused by hydrocephalus. MRI demonstrated large cellular and supracellular cystic lesions with calcification. The tumor extended into third ventricle, and transplant approach was performed. You can see the optic chiasm pituitary stalk SHA, and after debarking of the tumor and calcification, you can see the cyst wall. Cyst wall was dissected gently, and final foramen of Monroe was identified. Postoperative MRI demonstrated no decidual tumor. This patient presented with headache, preoperative three-dimensional fusion imaging, and surgical simulation demonstrated that tumor complex brainstem. Based on the location and extension of the tumor, we selected a transcribal and transpterygoid approach. Now we open the cell floor. The abnormal bone was drilled out, and lateral bone was also removed through the transethmoidal corridor to obtain an adequate surgical angle. Tumor debarking was performed using sometimes ultrasonic aspirator like this, and the cranial nerves are identified and carefully preserved. The tumor was gently dissected from the pons. The tumor was finally unblocked resection was achieved. Skull-based reconstruction was performed using the fascia and vascular nerve septal graft. Postoperative MRI demonstrated no residual tumor. Finally, I would like to discuss an unusual but clinically important imaging finding. This 65-year-old woman presented with visual disturbance. MRI demonstrated a pituitary macro tumor. Because of chronic renal failure, only non-contrast imaging was available. And on T2-weighted MRI, an intratumoral roboid was clearly identified. This finding suggested the presence of a hypervascular component within the tumor. In our series, intratumoral globoids were identified in approximately 12% of pituitary tumors. This finding may become increasingly recognized with the widespread use of high-field MRI. And another case, this 49-year-old man presented with panhypopituitarism and had a history of renal cell carcinoma. Again, intratumoral globoid was clearly demonstrated. The differential diagnosis of hypervascular cellular lesion, including tumor arising from the posterior pituitary. So these tumors are often highly vascular and may express TTF1. Angiography demonstrated a hypervascular tumor supplied mainly by the inferior hypophyseal arteries. An endoscopic endonasal approach was performed behind the anterior pituitary gland. This is the anterior pituitary gland. Behind the pituitary gland, highly vascular tumor was identified. After coagulating the feeding arteries, the tumor was removed. The final pathological diagnosis was pituitary metastasis from the renal cell carcinoma. This case emphasized the importance of recognizing unusual imaging findings before surgery. In conclusion, first, the classification of pituitary tumors had evolved dramatically. The transition from pituitary adenoma to PITNET reflects our increasing understanding of tumor lineage and molecular biology and clinical behavior. Then second, imaging is no longer limited to anatomical diagnosis. And third, advances in endoscopic skull-based surgery have expanded our ability to treat complex cellular and paracellular lesions. Finally, education is essential for the future of skull-based surgery. Thank you for your attention.
Very much, Professor Kurosaki. I think this has been a very comprehensive analysis of how cellular region tumor must be addressed. It is quite important, as you said before, most of the lesions that we treat with endoscopic endonasal approach are treatments that we implement for the treatment of pituitary adenomas in over 70% of the cases. And the analysis that you gave to us, trying to make a clinical correlation between the clinical aspects of the patient, of course, the findings on the MRI, and also with the pathology discoveries that we can find in some of the patients. Finally, I think that these belong to the organoleptic characteristics of the tumor. As you presented to us, when certain characteristics of the MRI indicates that you are going to face a patient with a solid tumor in the cases that you presented, and then you are able to perform precise lesionectomy of the lesion because the consistency of the tumor allows you to perform that kind of dissection. Obviously, there are some other cases in which the tumor is practically liquefactic, and it is very easy to take away the tumor. But you need to know this before you go to the OR in order to be prepared, also in order to have the proper reconstruction technique made before the approaching the tumor. So in this way, your chances of having complications are diminished. The invasion pattern of the tumors that you presented to us and the correlation with the MRI gives us a clear understanding of how the tumor is going to behave. And in your cases, you presented also the pathologic characteristics that belong to that clinical image and the course of the surgery. Obviously, when you go to different lesions such as craniopharyngioma, you said to us that we need to be more aggressive in the approach. And this is where the expanded endonasal endoscopic approaches take a big place, because exposition of the tumor is the first characteristic that you need to take into account. The analysis of the hypophyseal artery, the superior hypophyseal artery, is quite important, because sometimes you need to cut one of the branches so you can have enough space to go into the interpeduncular cistern. And the importance of the laboratory training that you show us gives the neurosurgeon the necessary tools to become familiar with the technique. Sometimes it's quite difficult to go to the interpeduncular cistern with the conventional endoscopic transcellular technique. So, as you show to us, you can expand your approach through the tuberculum sella and planum sphenidale, so you will have a quite grand view of the lesion. And for some other lesions, such as the chordomas, it is very important to address that also the bone is infested with tumor. So your approach needs to be tailored according to the characteristics of the patient, and for that the imaging studies are quite important, so you can have a good planning of the surgery, extending your surgery, as you show us, transclival, transpterygoid approaches, which must be reserved for those patients that will benefit with such a surgery. The vascularization pattern of the tumors, it's also important to be learned before the surgery, because as you show to us, the images that shows that you will have a very vascularized lesion is important during the surgery. You need to be prepared to have a proper hemostasis with adequate instruments, and in that way your surgery will be in good course. I think the analysis that you are doing and making this a critical clinical correlation between the patient, the image in the preparative period, also the careful analysis of the pathology is what we call now the integral neurosurgery for the patient. Obviously, if you have a good set of studies in the preparative period, good clinical analysis, you have a proper indication, and then you are more prepared for the surgery with a good laboratory training before. And in that way, it will be easier for you to perform the surgery. So for the young surgeons, it is quite important, because some of us, we learn in the OR, but it's really important to go to the laboratory to train in the techniques, to learn the techniques, so you will be prepared to perform an adequate and precise lesionectomy, as you show us in your wonderful videotapes. Thank you very much.
Thank you.
Thank you very much. That was wonderful, Professor Amador. We can take questions, a few, before we start the second. Yes, Ben has raised his hand. Ben?
I would like to thank you, Professor Kurosaki, for your great lectures. I have questions about what's your opinion towards the pure ventricular craniopharyngioma? If the lesion is entirely inside the third ventricle, what is your opinion towards this kind of the lesion? Would you go for the rescue of the endoscopic transnasal approach with extender approach, or you would go for the transventricular approach? And what are the considerations for you?
Recently, almost all craniopharyngioma cases, we do the endoscopic endonasal approach. And in some cases, the elderly patient, large cystic tumor patient, then we evacuated fluid collection and then radiation. Some methods, but mainly we do the endoscopic endonasal approach.
That's it. Thank you so much for your answer, and thank you so much for your comment in your great lecture.
Yes, Professor Amador?
Yes, I think this is a very interesting question, because there is a wide controversy point, as if you should go transcranially or endoscopic endonasal. Uh, Professor Kurosaki showed us the importance of the laboratory training. And if you saw in his video, you are able to see and to preserve all the structures located in the supracellular cistern, right? You can go around the infundibulum, you can reach properly the interpeduncular fossa for some cases, and we have here Professor Atul Goel. I think he will disagree with us in the fact that that you can take the tumor, all the tumor to the nose, because the microsurgical techniques show us that we are able to perform precise lesionectomy, complete excision of the tumor using also transcranial routes. Uh, I think it's quite a controversial point. I would like to hear your point of view, Professor Goel.
First of all, I must say that I really enjoyed Dr. Kurosaki's presentation. There is no question, right from the nomenclature, then the pathological variations, then the cadaveric dissections, then surgical beautiful techniques that he showed. I really enjoyed, and I congratulate you. And Dr. Raja, this presentation must form a very valuable part of your next series. I must tell you, and I congratulate you. Although I agree with majority of points, and to remove craniopharyngiomas, this from the nose, my strategy for removing craniopharyngiomas from the, is more often than not by a transcranial route. And that transcranial route is here to stay. It is safer. It is, under direct vision. And it is, you can dissect the stalk from the tumor capsule and things like that. So most of them, I'm not saying in my series, maybe about less than 15% of craniopharyngiomas are suitable for transnasal approach. So this is one point of difference from Dr. Kurosaki's presentation. Otherwise, all in all, I really enjoyed, no question about it, your technique of resecting small tumors, vascular tumors, big tumors. I really enjoyed. Thank you very much.
Thank you.
Thank you very much. We are short of time as Professor Visochi has other engagements, so we will straight away move on to the second session. Before that, I would like to thank Professor Kurosaki and Professor Amador for the time and support for the ACNS webinars. Thanks to Professor Shubin, today's webinar is broadcasted on WeChat, YouTube and Zoom. We have around 600 people live as of now on the 3 different channels. So those who have questions can type in their questions in the Q&A box. Professor Kurosaki can try to answer it online. So I'll hand this podium over to Professor Visochi to say a short introduction and invite Professor Sairam for his lecture.
First of all, I want to say hello to my big friend and brother, Professor Atul Goel. We have met recently in Mumbai for the beautiful Congress of ACNS, and I enjoyed so much. So the presentation that we are introducing right now is cerebrospinal fluid decompression strategy for Chiari malformation. And I'm happy to introduce the speaker. Please, you can start your presentation, and in 15 minutes, unfortunately, I will leave the connection since I have other duties. So I'm looking forward to enjoy your presentation. Please go ahead.
Good evening. Today I'm honored to present our works on Chiari malformation, and I'm very happy. And my topic is about the CSFD surgical strategy in Chiari. I'm Ronzi from Department of Neurosurgery, Huaxiang Hospital, Fudan University, one of the biggest neurosurgical center in China, and perform more than 200 Chiari cases per year. And I suppose that many surgeons are very familiar with Chiari malformation, and most of them think maybe Chiari is very easy, such as PFD can fix all the cases. But I don't agree with these points. If I were to choose a word to describe Chiari, it may be complex. Let us take a look at the history of Chiari. It's complex, which was first reported by Cleland in 1883 and systematically classified by Hans Chiari in 1891, and further elaborated by Arnold and his students in the early 20th century. So they may think this classification is to very helpful for Chiari therapy, but after more than 130 years, despite the tremendous advancement in neurosurgery, its measurement remains one of the most controversial topics in neurosurgery area. And we should know the complexity of the Chiari treatment, why we identified more than 1,300 articles on Chiari malformation in the literature. And each paper has different mechanism, different classification, and different surgical techniques. As Professor Gore, I believe he is online today, and stated in 2006, the number of form of treatment described by various surgeons is probably equal to the number of surgeons performing the surgery. And the deeper question is Chiari a formation or a malformation? If it is a formation, Chiari cases have micro or subtle instability of CVJ, and the cause of disease is originated from a dynamic adaptation, then fixation might be the key point. On the other hand, if it is a true malformation, a structural defect, and we need decompression, the CSF circulation restoration. So this debate continues, but the friendship between neurosurgeons also continues. Anyway, one thing is clear: individual treatment is essential. Also, the classification of Chiari is complex. Usually, Chiari is divided into 4 types, and the type 1 is the most common. And in 2024, Professor Visocci proposed the 7-type classification system in Precise Journal. So it is a more complex, containing type 0, that means crowded posterior fossa, and 0.5 is crowded posterior fossa with syndrome. We can think carefully if there are any other diseases that can be classified into 0, 0.4, and 1.5 types. It's interesting. And if we talk about the pathogenesis on the foundation of the Chiari treatment strategy, and the current evidence supports 5 major theories. And the first is anatomy abnormals. The Chiari always happened combined with an anatomy abnormalities such as sixth scroll and obliteration of cortical subarachnoid spaces and effacement of basal systems. And also congenital cranial synostosis and abnormal embryonic development are 2 important factors. But all the factors finally result in a reduced posterior fossa volume and alter the structure, increase the competition for limited space. We can imagine a room that is too small for its contents. Then cerebellum, brainstem, and the fourth ventricle are squeezed out through the foramen magnum. And the second mechanism is CSF dynamic abnormal theory, and old field theory showed that there are no obstruction at the fourth ventricle outlets during cardiac cycle, so CSF cannot smoothly into the spinal subarachnoid space. And also prepared by abnormal pressure waves as CSF impacts the spinal cord surface and enter the perivascular spaces. It then travels along small arteries into the deep spinal cord, accumulates in white matter, and coalesces into a syrinx. And the third theory, we just discussed this point in the previous slides, that many cases are combined with subtle atlantoxia or occipitocervical joint instability, and the chronic abnormal stress may alter posterior fossa structures and induce or aggravates cerebellar tonsil herniation. And the fourth is genetic factors such as Jackson-Weiss syndrome or CHD8 or CH3 genes. And the fifth is secondary to the other diseases such as intracranial tumors, epidural hematoma. We should not neglect these intracranial diseases, and every year we just meet several Chiari cases caused by intracranial diseases and got worse after simply PFD. It's terrible. So we can see Chiari pathogenesis is multidimensional. This complexity explains why treatment is so challenging. So if we talk about the pathogenesis of Chiari malformation, we should pay attention that there is no evidence to support elevated intracranial pressure, high ICP, or reduced posterior fossa volume. Several articles support these points, such as the resting ICP is normal in the vast majority of CML patients, and also about the reduced posterior fossa volumes, PCFV, the large image study showed that only 30 or 40% of CML patients have complete normal PCFV. And many individuals with small posterior fossa do not have tonsil herniation. And the true determinant is not simply the total bony volume. So these slides show that the evolution surgical concepts in Chiari, from the simple decompression to anatomy reduction and to CSF restoration, includes three stages. At the beginning in 1965, Gardner first did intradural manipulation to explore the opening of the central canal at the bottom of the fourth ventricle, but at that time it caused high mortality and disability. So intradural steps reduced instead of wide bony decompression become standard. And from 1990 to 2000, with MRCT widely used, the bone window reduced to 3 to 4 centimeter. But in many cases showed PFD could not fix all the patients. In many cases, the cerebrospinal could not be reduced or re-enlarged after early reducements. So after 2012, and the bone decompression with duroplasty or PCMR guided individual strategies were used, and finally after 2020, and outflow tract reconstruction and the CSF circulation restoration will gradually be the key point for Chiari therapy. And many evidence and papers confirm that Chiari malformation is consistent associated with abnormal CF dynamics, especially for PCMR application, and the CS flow speed could be detected. So in Chiari cases, we usually use the CS flow in the fourth ventricles and ventral at the dorsal foramen and magnum meningeal foramen was standard detected. And this paper showed the CM and the cerebrospinal are consistent associated with abnormal CSF dynamics. And these papers showed published in Spine and the World Neurosurgery showed that the CSF circulation restoration is the key to treat Chiari malformation and cerebrospinal. And the core principle is re-establish normal CSF circulation. And in 2024, New England Journal published the review article by Professor Freelander and review the central role of CSF dynamics in surgical decision-making for Chiari malformation. I think it's very important. And so this is a typical case NMR showed the Chiari with cerebrospinal, and during operation, we just found that extensive subarachnoid space adhesion and with fourth ventricle outlet obstruction. And the surgical field was seen distinct at a wide arachnoid tissue and sinking and fibrosis. So I think it's no use for if only PFD was done. So re-inquiry of the medical history showed that the patient suffered from meningitis at his childhood, and after tonsil resection and adhesion releasement, the cerebrospinal reduced significantly. And here is another typical case. This is a female 29-year patient NMR showed a mass significant enhancement at the meningeal foramen of fourth ventricle with cerebrospinal. And so the fourth ventricle hemangioblastoma was first considered. And we suppose the patient must be VHL disease, so the cerebrospinal is caused by another cervical cord hemangioblastoma. But after contrast, cervical MR contrast, and demonstrated that no any other tumor, we can see no any other tumor node. So we just remove the tumor. So we just remove the tumor through the embolization and the surgical resection. It's not easy, but it's not the main point. What I want to say is 1 day after operation, the MR showed the cerebral myelin reduced significantly. So this case demonstrates that the CSF circulation dysfunction, no matter caused by compression, adhesion, fibrosis, or congenital developmental abnormality, is the main reason of syringe myelin, and the CSF circulation restoration is the key point. So let me introduce our works, and first we just use the biometrics to evaluate the relationships of syringe myelin and Chiari, and find more than 50% of syrinx was caused by Chiari, which may disrupt CSF circulation. And in our basic work, we can see the cotton ball chronic compression model we used could exhibit a syringe myelin incidence more than 60%, while we just use the Collin model, which will cause a wide range of adhesion and fibrosis in subarachnoid space, demonstrate a markedly high incidence of more than 19%. Though this phenomenon once again confirmed that CSF dynamic dysfunction is the reason of syringe myelin. So we raised the concept of CSF decompression, CSFD. It stands for CSF restoration. So the surgical aim, is to restore the normal CSF circulation at the CVJ area, and the foundation is posterior fossa decompression with C1 laminectomy, and the key manual is include bilateral tonsil dissection and exposure and outflow tract reconstruction. Specifically, we aim to achieve 3 objectives. First, full exposure from the apex to the choroid plexus. Second, lateral repositioning of the tonsils without occluding the medial aperture. That means magenta foramen. And the third is the patency of both lateral aperture. That means Lushaka foramen. The end result should be unobstructed CSF flow. So CSFD is a concept, not a fixed methods. So we should pay attention. It's not enough. So we should pay attention not if only magenta foramen was exposed or dragged, because if without outflow tract reconstruction, separated bilateral tonsil will close and block the outflow tract again. So one challenge is that we currently lack quantitative indicators to guide the procedure. This is an area for future development. Though this concept has been published, and I'm very happy many new researchers agree with the point and have already used the CSFD concept to treat patients. So this is another typical case of a carrier with syringe myelin use CSFD, and the pre-operative PCMR showed that a significant difference of CSF flow around the CVG area. They get difference. So this is the video during operation. So first, we just want to dissect and only coagulate by bilateral tonsil. If we can just use a coagulation, that it's okay. And we just want to expose the magenta foramen, and we want to separate bilateral tonsils and make them not obstruct the medial aperture, the magenta foramen. This is apex. And we also see, we also release some adhesion of the arachnoid membranes. But we found we can see bilateral tonsil reposition is not well enough. They could not separate them well. So we decided to resect the tonsil under the soft membrane and continue to separate the tonsil to bilateral sides and extend the exposure of outflow tract. And we just use we also cut off the inferior medulla vellum. Then we can see maybe a membrane. We can see maybe a membrane here, covering the outflow tract. So after opening, we just stop here. After, sorry. So after We can see here. Yeah. After we open the membrane, we can clearly expose the outflow tract from apex to plexus, and full CSD was achieved. So post-operative MR showed that cerebrospinal was distinct, reduced. The CS flow was almost the same around the CVJ area, which means no obvious CS obstruction there. So to validate the CSF concept, we conducted extensive clinical research. At first, a retrospective cohort study, and this represent 30 years of data from Huashan Hospital. And we include more than 70 CM1 patients, making the largest retrospective cohort reported in the literature. And we show our experience of Chiari therapy. And first, we just found that the surgical treatment can significantly improve the prognosis of CM1, such as raise the JOA KPS VA score. And also, we just compared 3 surgical approaches, such as PFD, PFDD with tonsil coagulation or tonsil resection, and the CSFD. And the results clearly showed that the CSF achieved the highest CCOS after operation, and the significance was extremely strong. And we also identify the key prognostic factors such as age, symptom, duration, syrinx size, and the JOA or KPS score. So retrospective data alone are not enough, so we designed a prospective multi-center real-world observation study. And we enrolled more than 700 patients with complete follow-up data from 5 neurosurgical centers in China. And the patients were divided into 2 groups. The one group is received extended reconstruction of system magnums, we call the ERCM, and insuopathy of the lateral foramen and the meningeal foramen, and to restore CSF circulation. And the other group is standard bony decompression with neuroplasty. Though this is a step-by-step schematic diagram, and this is a primary and secondary outcome that we used. The patients enrolled were from 5 neurosurgical centers in Shanghai, Fuzhou, Lanzhou, Chengdu, and Guiyang. So we can see at 18 months of follow-up, the ERCM group showed significant better CCOS and greater cerebrospinal reduction compared to the bone decompression plus neuroplasty. This is not the main point. The main point is that, interestingly, within the ERCM group, there was no significant difference in outcomes between tonsil coagulation or tonsil resection, so between TI and the TC groups. This suggests that the key factor is not whether you remove the tonsils or not, or you use any other surgical methods, but whether you successfully restore CSF circulation. So after treatment, what concerns us most is a prognosis, so we can predict outcomes early after surgery. And to answer this question, we conducted a prospective study. Another study included 62 CM1 patients with cerebrospinal, and all patients underwent MR before surgery and within 72 hours after surgery. We defined ultra early cerebrospinal reduction as a 20% or greater decrease in the anterior posterior diameter of the cerebrospinal on sagittal MR within 72 hours, and divided into reduced and unchanged groups. So this slide shows that no significant difference at the baseline, and the results was striking. And the patients with ultra early reduction, we can see they had a significant better short-term recovery at the JOA score, JOA recovery rate, and the CCOS, also in the long-term improvement, and get a better long-term recovery at 1 year. So these findings has important clinical implications, and an MR scan performed just 72 hours after surgery can predict patients' quality of life 1 year later. This allows us to identify patients who may need additional intervention earlier and to provide more targeted rehabilitation guidance. And this is the figures also show that the ultra early ridge barrier reduction favor better shorter and longer term recovery. So we have found that the duration of symptoms negatively affects the CCOS score for Chiari. So traditional diagnosis relies on MR findings and clinical symptoms, but there are several problems. First, early detection is difficult. And the second, lack of objective quantitative diagnosis biomarkers. And the third, the symptom severity and imaging findings often do not correlate. This makes the clinical decision making very challenging. So we did some intelligent diagnosis and prediction works of Chiari. And first, to address this challenge, so we developed a blood-based rapid diagnosis system and assisted by multi-nanomaterial enhanced ionization mass spectrometry. This procedure only needs 0.5 milliliter of blood, just one drop, to identify 10 key metabolite peaks. And so the results were remarkable. In the training set, overall accuracy reached more than 94, and in the validation set, it was 93. And in the test sets, it reached 96%. The test sets containing one drop of my blood and certainly divided into health group. So it means that in the future, a patient might only need a single drop of blood for rapid Chiari screening. This could be particularly valuable for early detection in primary care settings and for monitoring high-risk populations. Of course, the technique requires further testing in large corpus. And finally, I want to introduce our latest achievement, an AI-assisted surgical decision-making based on preoperative symptom phenotypes. And why did we develop this? Because currently there is no universal surgical consensus. The choice between PFD, PFDD, and TC or TR largely depends on the surgeon's personal experience. No surgical procedure has been validated as superior to others. So CSFD concept still need one period of time for validation and acceptance by most of neurosurgeons. So we wanted to create a data-driven method to recommend the procedure for each individual patient. So we just use 30 years of data from 960 disabled patients at Huashan Hospital. As following steps, use AI assistant. And just simply as we created a phenotype-based classification of Chiari malformation and stratified the patient by preoperative phenotypes, exhibits distinct clinical outcomes, and also create the preoperative phenotype informed tri-class model. Then we establish a prognostic scoring system for identify patients with favorable outcomes. Then classification-based surgical decision support system was designed. The testing set could achieve nearly 75 to 80% accuracy for surgical decision making. So you can scan the barcode and fill the form of patient to get a suggestion for surgical decision. Okay, this is a summary of our works, and our goal maybe establish a comprehensive Chiari malformation treatment system, integrating basic research and clinical practice, and spanning from pathogenesis to clinical therapy to effective elevate and Chiari symptoms and improve their prognosis. Okay, this is our team. I would like to show my gratitude for their hard work. And also, thanks for your listening. Here's my email phone. We can keep touching in future. Thanks.
Thank you very much. Prof. Visochi has left, it seems. Nevertheless, we have Professor Atul Goel here. We can invite comments from Professor Goel.
No, this was a very elaborate presentation, Dr. Zai. And you know what I have to clearly say, and I speak from my heart, I can tell you, now I have been doing Chiari malformation by only atlantoaxial fixation for last 20 years. with an experience of nearly 650 cases. I know there is controversy. I know there is difference in understanding, difference in perception, and various things I clearly understand. But if you look at my understanding and perspective, I am absolutely convinced with the kind of results I am getting that Chiari malformation is secondary phenomena. It is not a pathology. It is secondary to chronic atlantoaxial instability. Atlantoaxial stabilization is the treatment. And that is, I am convinced. And I wish, Dr. Zai, that you work on this perspective and think about it more and come to this conclusion, because I have no hesitation. And when I am speaking so positively and so affirmatively, yes, this is the treatment, you think about it. I'm in academics. This is not a political forum. This is an academic forum where I am saying my view. I know your work, your various things that you have presented on various aspects of this very complex issue, but this is mine. I want your comment on this, and I also want Dr. Huan's comment on this, if he can give some comment on this subject. Dr. Visochi is here with us, Raja.
Yeah, he joined back. Yes, Prof.
I'm sorry if I ask to make a short consideration before I leaving, because I have another duty right now. But I appreciated so much the beautiful presentation of the Chinese colleague. I completely agree with Professor Atul Gore's consideration. He has a special interpretation, a special vision that many of us share with him. I think that the main concept is that Chiari malformation is a formation. And the term formation was first conceived by Professor Atul Gore, even though it seems very intuitive concept, but no one explain it at the same level of Professor Atul Goel, showing us that Chiari is exactly a tonsillar herniation, as the one that the colleagues showed us with the beautiful slides of brain herniation in different pathological conditions like brain tumors or brain hemorrhage. So tonsillar herniation is the consequence of something. Something can be divided in two main concepts. Number one, compression. Number two, attraction. Number one, compression is due to hydrocephalus, craniosynostosis, tonsillary scarring. Number two, attraction, like filum terminalis tethering the spinal cord, or idiopathic intracranial hypotension, mimicking a Chiari malformation, but it is a tonsillary traction by intracranial hypotension. When we consider and share these concepts and the Atul Goel intuition, I think that we understand the pathophysiological basis underlying the Chiari formation, and so we can proceed with the appropriate surgical option. Otherwise, we are going to produce contradictory results. So, congratulations to the Chinese colleague and his beautiful lesson, and also his consideration on reduced surgery with the better opening of fourth ventricle, in other words, and mainly to Professor Atul Goel for have conceived first the concept of formation. I apologize to all of you. I have to go. I'm late, and thank you so much for the invitation. Looking forward to meeting you all in the next future. All the best. Bye-bye. Thank you.
Thank you very much, Prof. Visochi, for taking out your time. Any comments from Professor Juan Luis Gomez?
Yeah, I think I agree with the commentaries by Professor Goel and Bisoshi. Professor Xie showed us a very careful analysis of the international literature concerning the causes and the various kind of treatments that have been implemented to treat this condition. Of course, if there is a secondary issue to be addressed, we need to go for the leading cause, not the symptoms or the findings in the MRI. And as Professor Atul Goel said, and Professor Bisoshi also, I think for those cases in which there is no secondary lesion to be treated, we need to correct the the instability and also the anatomical conditions of the craniovertebral junction. So in this way, we can give the patient what the patient needs. Also, the diagnosis of these patients in some instances could be very difficult because there are just subtle clinical findings, and sometimes it's quite difficult to reach a proper diagnosis. But I thank you very much for your excellent lecture. I think your analysis was very careful, and we need to be open all the time to the proper treatment of a patient, as Professor Atul Goel said before.
Thank you very much. I would like to ask one question is Professor Sairong, how do you close the dura at the end of surgery? Do you use a prosthesis or pericranial graft or something like that?
No, we just stitch it directly. Because I think if we just see circulation with well restoration, so it's not important for also duroplasty. So especially in Chiari malformation type 2, because this because the brainstem is just lower, and so sometimes we just need not to do PFD. So I have several cases, and I will analyze in future. And we just cut off you open the dura, and we just do CSFD. So we no need to remove the occipital bone. So we can achieve a very good result for cerebral myelin reducement. So this is this I think the main point may be the CS circulation restoration. But I don't think our CSF concept, such as the exposure from the apex to plexus, sometimes we just open the inferior medullary velum. This may be very big or sometimes dangerous. But I think this if we met some complex cases, that this is maybe a method for us. But sometimes just you use simple PFD, and sometimes you just use the PFDD or duroplasty. It can achieve a good results. But the question is how we can predict this. If we can just give us MR, we can predict if this PFD is useful for this patient. And I also answer the Professor Gore's question. I agree with your opinion that many cases is CVJ instability. But I think these cases in Chiari, if we could not find the atlantoxyl dislocation, this instability is micro or subtle. But how we can use the MR imagery just to find this micro instability. So sometimes we just fix the Chiari malformation, we just do C1, C2, which is a fixation, and we can get some good results, and sometimes not. So how we can choose these patients? For surgical decision making, this is very, very difficult sometimes. So if we met a case, we cannot find which surgical decision is the best. So we just use CSF concept. We just restore all the CSF circulation. We just make the CSF flow smoothly. So I think that this can treat all the Chiari malformation, but sometimes we could not, if we could not make the CSF restoration well. So this is maybe the symptom or the syringe malleable maybe not be.
Thank you. Prof. Goel, would you like to say your concluding remarks?
You see, Chiari malformation is a very bad disease. No, it starts with problems, some tingling in the hands, then weakness in the hands, then weakness in the legs, stiffness of the legs, then sleep apneas, voice disturbance, breathing disturbance. So it is a very slow, as Dr. Zai has said, slow, subtle, progressive disorder. It is a progressive disorder. Neck pain is a very common symptom, and very first and the last symptom, neck pain, restricted of neck movements. So it is a relentlessly progressive disorder, and it leads ultimately from some nuisance to crippling to disabling and ultimately a miserable death. So we have to understand this issue properly. More the people putting their heads together and understanding this will eventually lead to a treatment philosophy in service of our patients. All in all, Raja, I'm very happy that you organized this event. Thank you.
Thank you very much. I will close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Masamichi Kurosaki and Professor Sairong, as well as the Chair, Professor Juan Luis Gomez Amadora and Professor Massimiliano Visoci, for the time and support for the ACNS webinars. A special thanks to my co-host Liubun Seng and also Ben for joining me today. Before we close, I would like to mention that we have a ACNS app which is live as of now on both Google Play Store and Apple App Store. You can download it. And all these videos are archived there. Currently there are around 1300 lectures which have been grouped topic wise, and it will be a wonderful resource for all the neurosurgeons around the world. So until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.